Respected panel of judges and my dear friends, myself Joel Sabu. I am from Father Muller Medical College, Managlore, Karnataka. Today I'll be presenting a case of a 75-year-old gentleman who was a retired bank manager, married, from a Christian family and hailing from Managlore, Karnataka. The patient came to the emergency department with complaints of generalized weakness since 5 days, retrosternal pain radiating to back since 5 days. The patient was apparently normal 5 days before the entrance to emergency department at 13 p.m. He gave history of generalized weakness and also complained of intermittent burning, retrosternal chest pain and epigastric pain that was radiating to the back with no relation to feeding. He had a clenched fist to his chest on admission. He also gave a history of nausea, vomiting and cold sweating. The content of the vomit was eaten food and without blood and bile. There was no reduction of pain on bending forward. The patient didn't give history of dyspnea, melena or fever. The patient was hospitalized for 1 day before the entrance to emergency department due to the general deterioration. He was hypertensive and he was also admitted to CCU due to ischemic heart disease. The patient didn't give a history suggestive of diabetes mellitus, TB, measles, jaundice, trauma or injury. The patient was sleep deprived. His bowel and bladder movements were normal. He didn't smoke, consume alcohol, or abuse substances. His father had died due to myocardial infarction and both his parents were hypertensive. On general physical examination, the patient was conscious and well oriented to time, place and person. His pulse rate was 100 beats per minute, normal rhythm, normal character and blood vessels were palpable on both sides. The blood pressure of the patient was 100/60 mm of mercury, supine position and on both arms. The respiratory rate was 18 per minute, thoraco-abdominal. The temperature was 35 degrees centigrade and axillary oxygen saturation was 90%. He was having pallor, peripheral cyanosis, clubbing and cold sweating. The inspection was conducted in a well-lit room. He was exposed from below neck till pubic symphysis and the examination of neck veins showed no engorgement. On examination of inside the precordium, there was no deformity in shape, no pulsation of engorged veins, polythelia or scar marks were found. On examination of outside the precordium, no pulsation was seen. On inspection of the back, no scoliosis, kyphosis, gibbous, drooping of the shoulder, winging of the scapula were seen. No midline sternotomy scar suggesting coronary artery bypass surgery, left submammary scar for mitral valvotomy, and infraclavicular scar for implantation of pacemaker were seen. On palpation, the apex beat was palpable at left fifth intercostal space. No thrill was present. On auscultation, the cardiac rate was increased. S1 and S2 were detected with no pathological sounds or murmurs. On examination of other systems, there was normal vesicular breath sound heard on examination of respiratory system. On examination of abdomen, guarding and distension weren't seen, but the patient was having mild epigastric tenderness. On summarizing, a 75-year-old gentleman who was a retired bank manager, Christian and married, hailing from Managlore, came with a chief complaint of generalized body weakness for 5 days with intermittent retrosternal chest pain and epigastric pain that was radiating to back and associated with vomiting and cold sweat. He also had a clenched fist to his chest. He had past history of ischemic heart disease with CCU admission and hypertension. On physical examination, his BP was 100/60 mm of mercury on both arms and oxygen saturation of 90% was seen. He had a mild epigastric tenderness. The provisional diagnosis of the case is it is a case of generalized weakness and retrosternal pain radiating to back in a 75-year-old gentleman with a possibility of coronary heart disease. The differential diagnosis includes acute coronary syndrome, aortic dissection, acute pancreatitis, peptic ulcer perforation, and bowel perforation. The patient wasn't showing any variation in BP on both hands, and he wasn't having any paralysis, oliguria, or other renal symptoms. Thus, I ruled out aortic dissection. The patient wasn't having any decrease in pain on leaning forward, which made me to rule out acute pancreatitis. The patient wasn't having any pain associated with feeding, which made me to rule out peptic ulcer perforation. As in the case of bowel perforation, I was able to rule out because the patient wasn't having any tardy pulse or shock. Thank you so much.